All right, so today I'm going to be talking to you about life after allo stem cell transplant. So those months after you've been allowed to go home from the transplant centre and up to about the first year. So you've spent about 3 to 4 months under the intense gaze of your transplant team if you come for an allogeneic stem cell transplant. They've been keeping their beady eyes on you for about before and during and after that transplant, and they've now said that you can go home. It's normal to have mixed emotions about this. On the one hand, it's really exciting to be going home and going back to those that you love. But oftentimes there's some worries and concerns for both you and your whānau. It's normal to be a bit scared. You have been intensely monitored during that time of your transplant, and then all of a sudden you're back home and no nurses or doctors are there with you. Rest assured that your transplant team is only a phone call or an email away. So if you've got any worries or concerns, certainly in Wellington, but I'm sure it's the same elsewhere as well, they'll be more than welcome for you to contact them. It takes a bit of time to settle back down at home and establish a routine again. It's a real time of transition for you and your whānau, and you're likely to experience highs and lows in the months ahead. Even if you have been allowed home, or even though you are allowed home, you won't feel back to normal yet. You're likely to still feel pretty tired, have poor appetite, and will almost certainly still be taking a stack of tablets. With these things in mind, I want to talk to you today a little bit about some of the things that you may experience over those months when you're at home. Leaving us and heading home is an amazing step towards your recovery, and I don't want to take anything away from that. But in the world of transplant, you have to expect the unexpected. Things crop up, and so today I'm going to talk to you about some of those things that you might come across. So things that we're going to cover today are here. There's so much that we can talk about in this phase of recovery, and I just don't have the time to do that. We could probably spend a whole day. But we're just going to touch on settling back in at home, fatigue, infection, graft versus host disease, fear of recurrence, sexuality, and returning to work. It's a bit of a heavy-duty list of topics, sorry. By the time you've got to the point of going home, though, you've achieved so much. Being aware of what may happen in this phase of your recovery will help you to pinpoint things early and get help if there's any issues. So let's begin at the beginning, going home. So heading home from your transplant centre is an exciting time, as I said, another big step in your recovery. But heading home can be also a little bit stressful and a bit scary for both you and your whānau. You had round-the-clock safety net of nurses and doctors when you were at your transplant centre, which you won't have at home. Now you will be monitoring your own health on your own, and this can be a bit stressful. This is a time for adjustment, and be rest assured, as I said, you can contact us if you've got any questions or concerns at home. When you get home, you may find that family roles may have changed because of having your transplant. So, for example, you might have been the person responsible for running the household, so that when you get home, you might need to have help with these tasks while you recover. This can be really frustrating, but as you get stronger, you'll be able to start doing more of those things that you're used to doing around the house. You may find when you go home that you look different, particularly if you've had or having medications to control graft versus host disease, and this may make you self-conscious. If you're taking steroids to control graft versus host disease, then you might experience mood swings. This roller coaster of emotions can be hard for both you and your family, and you need to make allowances for each other. It's a time for patience with each other and open and honest communication. You may find when you get home, you may be the star attraction for a little while. You've been away from home for quite a while, and your friends and family will want to catch up with you and see how you're doing. We encourage you to catch up with people, as it's really important to re-establish those relationships again, but just check in with them to make sure that they don't bring any illnesses into your home. When you get home, we want you to start living life again and slowly getting back into doing the things that you love doing. You're going to feel quite tired and weak for a while, so don't go trying to do everything all at once. Just ease back into things slowly. This can be frustrating, but be patient. You will get there. So fatigue, as some of you might have experienced already, is a really common symptom when you've had chemotherapy, and the same is for when you have a transplant. It's something you're very, very likely to experience when you're at home. It affects both the patient and their whānau, and sadly it hangs around for a while and is slow to resolve. Fatigue is associated with physical, psychological, social and spiritual distress, and results in decreased physical activity, mood changes, sleep disturbance, and can really impact on your quality of life. The fatigue post a stem cell transplant is different from the fatigue associated with everyday life. It's usually more severe and more distressing. So fatigue might be experienced in a number of ways. You may feel like you have less energy. You may also feel like you are generally weak and have a sense of heaviness of your limbs. You may feel a complete lack of motivation to do anything at all. You may feel that you want to sleep all the time, but you may also feel completely exhausted and not able to get to sleep. It may be that you do sleep, but you still wake up feeling tired. It may impact on your memory and your ability to complete daily tasks. From an emotional perspective, it can be a frustrating reminder of all that you've been through. And it can be really unpredictable, which sometimes makes it difficult to manage. So what causes fatigue? Well, it's very multifactorial. So the intense chemotherapy and radiotherapy that you've had as part of your transplant treatment will contribute to this. If you're anemic or got low blood counts, if you've got a bit of depression, you will have lost some physical condition during your transplant, which is very common. You may be a bit malnourished. Your thyroid might not work very well, so you've got low thyroid hormone levels. And some of the medications that we give you in the post-transplant period can also impact on this. The reality is that it's probably a number of these things altogether and no one single thing. So I guess the take-home message about fatigue is that it will get better, but it's going to take time. And I mean months rather than weeks. Chronic fatigue is not helped by just getting more rest or sleep, which seems a bit weird because in our heads when we're tired, what we want to do is rest and sleep. In fact, even though getting good quality sleep is important in managing fatigue, it's important not to get too much of it. Daytime sleeping will impact on your ability, on the quality of your nighttime sleeping, and it may also result in a complete reversal of your sleep patterns so that you're sleeping during the day and awake at night. If you do find that your sleep patterns are completely reversed, then getting some cognitive behavioural therapy is more likely to be a more effective tool for improving sleep than taking sleeping tablets. Physical activity that strengthens muscles and improves stamina is critically important to reducing fatigue. Once again, this feels like a counterintuitive thing because if we're tired, we want to rest more, but actually exercising is one of the most effective ways to help alleviate fatigue. I don't want you to go out and all of a sudden do a 5K walk and lift 20 kilo weights. You need to start slow and build it up. So for example, start going for a walk for 5 to 10 minutes 2 or 3 times a day and just slowly build that up. If you go at it like a bull at a gate, you're not going to be able to get out of bed the next day. So long and slow is good. You could also involve a physio or rehab organisations like Pink and Steel to help you get back on your feet. Eating a good balanced diet with enough protein, carbohydrates and calories will also help resolve fatigue. This also can be really hard to do when you're at home. Your taste buds still aren't working properly and food doesn't taste right, and you often don't have much of an appetite either. During this time, you kind of need to think of eating as a job to get well rather than a pleasurable experience. Energy conservation strategies like pacing yourself, scheduling your day so that important tasks are done when you have the most energy, and delegating tasks to others also often help. If part or all of your fatigue is related to an underactive thyroid, then your doctors can treat that very easily with some thyroid replacement therapy. So moving on to infection. So when you go home, you're still at risk of picking up an infection. You have more immune protection than when you were in the hospital because you've got some white cells to help in that fight. However, fighting infection involves a number of different immune cells, and it takes around about 12 to 18 months for all the different immune cells to be working properly. Your immune system is like a baby's at this point. It's brand new, and it needs to mature to be able to fight infection properly. So some general tips for preventing infection are here. You know these already, I'm sure. Your nurses will have drummed them into you. But the most important infection prevention mechanism is to wash or gel your hands well. After going to the toilet, before you eat, after being on the bus, everywhere. But you should also stay away from people who have been sick or who are sick, and avoid being in crowded spaces. If you can't avoid those things, then wearing a mask is important. And I'm sure also that you know what to do if you feel unwell or if you have a fever of 38 degrees or more. You need to get in touch with your transplant centre or haematology team immediately for advice. Or if you can't get hold of them, present to your hospital's emergency department. And I'm sure most of you have a card that's something like this. It's your Get Past Go card. It will get you into the emergency department quickly and getting some treatment faster. So let's look at how you can help prevent getting infections. So your medical team will have prescribed some medications like valacyclovir to prevent shingles, cotrimoxazole to help prevent a lung infection called pneumocystis, and antifungal medicines like posaconazole or fluconazole to help prevent fungal infections. It's really important that you take these. They support your immune system to prevent from getting unwell. We also recommend that you avoid gardening, which is quite distressing to a lot of people, dealing with potting mix and flower water. There are bacteria in these things like Legionella and Pseudomonas, and these are bugs that you really don't want to get. Also try and avoid being around renovations. Fungal spores hang out in old houses and behind walls, so demolition poses a problem for getting a fungal infection, something again that you don't want. Keeping our homes clean is something that we should all do, but with a baby immune system, it's more important as it does play a role in preventing infection. You can be at home with your pets. Just please make sure that they're well and they're up to date with their vaccinations. And you should avoid clearing out litter trays, which is quite good news, I think, and try and avoid them licking and scratching you. If they do, please wash your hands. Vaccines play a big part in educating your new immune system and how to prevent infection. Your transplant causes you to lose immunity to a lot of diseases that you were vaccinated against as a child. For example, polio, diphtheria, measles, whooping cough. Approximately 6 months after your transplant, when your immune system is a little bit more mature, we start a vaccination program. Over the course of several months, we vaccinate you against those illnesses that we've talked about. Most vaccines are made using a denatured or dead bit of virus, and these vaccines will not cause the illness they're trying to prevent. There are a couple of live vaccine viruses, such as the measles vaccine and one of the varicella vaccines, that cannot be given to you until you're at least 2 years after your transplant and have been off your immune suppressing medicines for at least 3 to 6 months. You're at risk of getting these illnesses if you have the vaccine whilst you're on immune suppression, or if your immune system isn't mature enough to cope. We recommend that you repeat the course of your COVID vaccines, and that can be done from 3 months after your transplant, because you will have lost immunity to that as well, and always make sure you get an annual flu vaccine. Okay, so moving on to graft versus host disease. So graft versus host disease is something that you have likely heard about or perhaps experienced already. It's a massive topic, and I'm really only going to skim the surface of this today. So GVHD is a complication of allogeneic stem cell transplant that is potentially life-threatening and may have a significant impact on a person's quality of life. During an allogeneic stem cell transplant, the recipient receives stem cells from a donor. Within that donation are T cells, which are a type of white blood cell that help protect the body by recognising foreign invaders like viruses and bacteria and destroying them. T cells also attack leukemia and cancer cells, which is how the allogeneic transplant works. However, donor cells, known as the graft, may also attack the patient's healthy tissues and organs, so the host, which can impair the tissue or organ's function or may cause it to fail. So this is called graft versus host disease. Around about 20 to 60% of allogeneic transplant recipients will get some form of graft versus host disease, so it's very common. The onset of this is usually after the donor cells have engrafted or start to grow. It varies in severity. It may be mild, where you don't need any treatment at all, or it might be moderate or severe. And it affects lots of different organs in the body. There are different types of graft versus host disease. So acute graft versus host disease is usually seen early post-transplant and mainly affects the skin, liver and gut. Chronic graft versus host disease is usually seen later in the transplant course, usually after 3 months, and it can affect just about any organ system. And then there's an overlap syndrome where you can have a little mix of both. So this acute graft versus host disease occurs most commonly when you're still staying at the transplant centre. So I'm only going to touch on this very briefly, but it usually occurs within the first 3 months after the transplant. About 30 to 70% of recipients will get some form of acute graft versus host disease. And as I said before, it usually affects the skin, which you can see with this picture here, the gut and the liver. Treatment of this is with steroids, prednisone or steroids through your drip. If it's a mild skin rash, then we can put some topical creams on, but otherwise we give it to you in tablet form. And if you have liver and gut GVHD or significant skin graft versus host disease, we will give you systemic steroids, in addition to adding or increasing the dose of other immune suppressing drugs. Good supportive care is also really important in the treatment of acute graft versus host disease. Chronic graft versus host disease is something that you're more likely to see when you're at home rather than the acute post-transplant phase at the hospital. It's the most common late complication after an allogeneic stem cell transplant and most commonly occurs at around 6 months after the transplant. However, there's a group of patients that don't get it diagnosed quite late, so well after a year after the transplant. It may be seen when the doctors are cutting down your immune suppression tablets. And it affects many different parts of the body. It's a very different clinical picture to acute graft versus host disease. It often looks more like an autoimmune disorder. Once again, affects a lot of patients, so 20 to 70% of patients after day 100. It is definitely associated with decreased quality of life, and in severe cases may be a cause of death. So over the next few slides, I'm going to go through some of the organs that may be affected by chronic graft versus host disease. So skin is the most common organ to be involved. It may be that you get rashes, a change in skin colour or texture, itching, burning or tightness or stiffening of your skin, or swelling in your hands and feet and legs. Treatment, as with most graft versus host disease, is about your immune suppression medicines. So we can once again use steroid creams for the rashes or systemic medications. For skin graft versus host disease, it's really important to use lots of moisturising and emollient creams because your skin gets really dry, and sometimes your sweat glands and your oil glands don't work properly. It's really important to avoid the sun and avoid things that are going to irritate your skin, like harsh laundry detergents and perfumed soaps and creams. So keeping things simple is good. The mouth is another common site of graft versus host disease. Patients experience increased sensitivity in the mouth or pain. People can get a very dry mouth, have ulcers, have white kind of lacy cobwebby things or white patches on the inner cheeks, like with this photograph here, or purplish and reddish areas on the lips or inner cheek. And some people, if the skin around their mouth is stiffened up, are not able to open their mouth fully. Treatment of oral graft versus host disease is once again about immune suppressing, this time more topically based, so mouth rinses and creams to help. It's really important that you take good care of your mouth, so see your dentist regularly, using fluoride gels and rinses to prevent tooth decay, and brushing and flossing your teeth regularly. If you have a dry mouth, then using artificial salivas or rinsing your mouth often with water is good. Chewing sugarless gum to stimulate saliva production sometimes works, and using water during your meals to moisten your food helps with chewing and swallowing. I suggest that you avoid drinks with caffeine and alcohol, as they dry your mouth out even further, and spicy or salty foods can cause a bit of discomfort. Eyes can often be affected, often very non-specifically with some eye irritation, but GVHD of the eye, the signs of that include dryness and grittiness of the eyes, redness and burning and pain, sometimes some gunky eyes, sensitivity to bright lights, blurry vision, and eyes that tire really easily. Dry eyes can make you feel really fatigued. Treatment for this is about rehydrating the eyes, so using preservative-free artificial tears to keep your eye surface moist, and at night using ointments that have a bit of longer lasting hydration in them. There are medical interventions like blocking tear ducts or topical immune suppression medicines that can help, or serum eye drops. Lung graft versus host disease may cause scarring in the small airways in the lungs that interfere with the breathing out of air. The signs of this are a dry cough and a decreased ability to exercise. It may begin silently and you may not notice any symptoms, But regular lung function testing is done by your transplant team to try and detect this early. Once again, it's all about immune suppressing medicines, and this time using inhaled steroids and bronchodilators to help with your breathing. The gut can also be affected, and it affects the whole of your gut from your lips to your anus. So signs of gut GVHD include a loss of appetite, nausea and vomiting, some tummy cramps, weight loss, diarrhea and bloating. Once again, immune suppressing medicines are the key to treatment. There's a topical steroid called budesonide, which we can use, that bathes your gut with steroid to help treat inflammation, but it doesn't get absorbed into your system. However, we sometimes need to increase your immune suppressing medicines as well. And other supportive care medicines like antidiarrheal medicines and anti-sickness medicines are also important. Liver graft versus host disease really causes symptoms. It's mainly picked up by your doctors and nurses on blood tests. However, if you have severe liver graft versus host disease, it can cause you to become jaundiced because the bile is not being cleared out of your system very well. Once again, treatment is associated is using immune suppressing medicines, but we also want to rest your liver as much as we can, and we give you a medicine called ursodeoxycholic acid. We want people to avoid over-the-counter medicines and homeopathic remedies unless we know exactly what's in them, because sometimes those are a little bit more toxic to the liver. And of course, we should avoid alcohol. So female genital graft versus host disease affects the vagina and vulva, causing dryness, itching, pain, ulcers and scarring, meaning that sex may be very uncomfortable or painful or not able to be had at all. Management is hormone replacement therapy if you are premenopausal going into transplant, and the use of estrogen cream topically to the vagina helps keep that pliable. We do encourage you to have sex. So using water-based lubricants is very important, but it helps keep the walls of the vagina apart and stopping them from sticking together. If you're not sexually active, we encourage the use of dilators. But it's really important that you see a gynecologist regularly. It also affects the male genitalia, so the skin on the penis and the scrotum is affected with itching, scarring, pain, or abnormal appearance. Management again is the use of topical steroids and moisturising creams. And in the uncircumcised man, a circumcision may be required. So graft versus host disease is a really common complication post-stem cell transplant. I've painted the bleakest picture, I think. It may have significant impact on your quality of life, but it's not a given that you're going to get it, and it's not a given that you're going to get it everywhere. But it is absolutely something that you must be aware of. If you think that you may have some signs of graft versus host disease, then get in touch with your haematology team. It's better to get on with treatment early if need be, because you have better outcomes. And no question is a silly question when it comes to this. So from one sobering topic to another, the fear that you'll relapse. This is also a really normal fear, especially in those first few months after the transplant. This is a significant concern for you and your whānau, and you are often hyper-aware of your body. So knowing your own body will help you distinguish normal physical changes and more serious symptoms that need to be reported to your doctor. Fear of recurrence does tend to diminish the further you get away from the transplant. However, there are often touchstone moments where that fear can be reignited, like coming to the hospital to see us for your follow-up appointments. anniversary days of your diagnosis or your transplant, or if you are experiencing symptoms like when you were first diagnosed. If you experience fear of recurrence and begin noticing some of the following signs, then this may indicate that your fear is becoming a problem and you should seek help. So if you're unwilling to return to a full life because of fear, having a relapse is a constant preoccupation or worry, if you can't concentrate, if having a minor problem like a common cold raises a strong fear that the leukemia or the illness has returned, if you're having long-term sleep problems, if you don't have any appetite, or you've got reduced desire to spend time with those that you love or participate in activities. If you've got any of those issues, then talk to your transplant team. They can refer you on to counselling, or talk to our support workers at LBC, because they will also be able to help. Acknowledging and talking about your fears is important. Be honest with yourself and your family, friends, doctors, and other support people about how you really feel. Family and friends can be a good source of support, so speak to them about how they can help you when you're feeling anxious or fearful. If you find it hard, try writing your feelings down in a journal. It might give you the confidence to speak. Don't be afraid to contact your CNS or make an appointment to see your doctor if you have a symptom that concerns you. Participate in your regular cancer screening programs like bowel screening or breast or cervical cancer screening. If you have concerns about cancers not routinely screened, then contact your GP for some advice. Come to your follow-up appointments. Some people don't. Some survivors find follow-up appointments really stressful. It triggers that fear again. So write down what you want to discuss with your doctor before you go. Look after yourself. This means taking care of both mind and body. Making healthy lifestyle choices to stay well may help you feel more in control of your health. Try to eat a well-balanced diet, exercise regularly, maintain a healthy weight, and get plenty of sleep. Avoid too much alcohol. A poor diet, alcohol, and recreational drugs can worsen fears and anxiety. Try to reduce the stress in your life. Some people find relaxation, meditation, mindfulness really useful. And once again, LBC is really good at helping you with where to begin with these. Continue with your hobbies or take up new ones. So staying busy, doing things that you enjoy can also help you cope better with your fears. There may be times when it's useful to have support that does not involve family and friends. So support from a professional who is experienced in survivorship issues may be more suitable. So if you want this, please get in touch with your transplant centre or else our friends at LBC again. So sexuality. So a transplant affects sexuality and intimacy in many ways, and it affects men and women and the transplant recipient and their caregiver. Sexuality and sexual dysfunction are one of the most important quality of life concerns after a transplant for both recipients and carers. But what we find is nobody wants to talk about it. Many healthcare professionals and patients struggle with this topic, and finding a way to start the conversation can be really hard. Sometimes it's handy to write down notes or questions before you come to clinic. It will help you feel more organised and give you the confidence to speak, or else if you're too embarrassed, you can just hand the list to your team. Think about when you'd like to have these discussions and how. Would you prefer an over-the-phone conversation or a face-to-face one? Sexuality is complex and it involves more than just having sex. It includes intimacy, body image, so how you think about how you look, sexual desire, and the ability to have sex. It's linked to our need for closeness, intimacy, the need for touch and caring. Physical changes caused by the transplant, such as weight loss or weight gain, changes in skin colouring, hair loss, hormonal changes, energy levels, and the functioning of sexual organs all influence our feelings about sexuality and sexual appeal. Transplant places a strain on the intimate relationship that you have with your partner. It's sometimes hard to make the switch from being a patient or caregiver back to seeing your partner as a sexual being. During this time, it's really important to maintain open, honest communication with each other. You may need to get to know each other in a sexual sense again, so think about doing things like holding hands, going on dates, cooking a romantic dinner, massage or cuddling. There's no set time for resuming sex after your transplant. You can resume a sexual relationship as soon after discharge as you feel ready. But it's really normal to find that you've got no interest in sex at all to begin with. Sex is just like exercise. It's harder to resume if you haven't been doing it for a while. So you may need to start slowly by finding ways to initiate contact to build from there. You might want to start by bringing some fun and non-physical ways and to bring romance and intimacy into your life. If your desire to become more sexually active does not increase as your recovery proceeds, then bring this up with your transplant team. It is important to remember that, as with a lot of other things after a transplant, getting back to normal takes time. So be patient with yourself and your partner. Help is available in terms of counselling and support. Once again, you can talk to your transplant team or the guys at LBC. They'll be able to refer you to appropriate services. We do have some recommendations around resuming sex, so ideally use a condom to protect against infection. Your partner should be well. You may receive oral sex but shouldn't give it until after you're off your immune suppressants. Vaginal dryness is really common for women, and so using a good water-based lubricant is important. Avoid anal intercourse while on immune suppressants, and use birth control until your fertility status has been formally assessed and confirmed as being unlikely to be able to conceive. Dating can be nerve-wracking at the best of times, but more difficult after a transplant. Once again, there's no right time to begin this, it's just when you're feeling confident and ready. Telling your new partner or prospective partner about your transplant is also entirely up to you and what you tell them. It's probably best to talk about what you've been through before things get too serious. However, if there are important things like fertility concerns to talk about. Returning to work can feel exciting and is a big step in your recovery, but it may also be a bit daunting, especially if you've been off work for a long time. Making a return to work plan in conjunction with your employer before going back to work is really important. This needs to include the date that you're going to go back to work, the role that you're going to return to, the hours that you're going to work, and you most likely need to start very part-time and increase your hours as able. It needs to include any adjustments that may need to be made, so maybe negotiating to work from home for part of the time, or some flexibility in your hours to allow you to work when you've got the most energy. It needs to include concerns that you might have about returning to work, for example, what your colleagues' expectations might be of what you'll be able to manage, and also how your pay will be affected by any changes. It's important that your return to work plan is documented in writing and that both you and your employer have a copy. It's also important that the plan be reviewed regularly. It may be that you're coping with going back to work really well and want to increase your hours and responsibilities faster, or else you may be struggling and need to stay on the same hours or even reduce. When returning to work, you don't have to tell your colleagues or clients about your transplant if you don't want to, and any health information that you've shared with your employer must remain confidential unless you've given express permission for it to be discussed. When you go back to work, catching up with training and meeting up with your colleagues to help get you back to speed is a good thing to do. But it does have its challenges. So fatigue may rear its head again. It's very common when starting back at work, and that gradual return to work of starting part-time and slowly building up your hours is important. Negotiating flexible work hours may help with this. As I said, you can time your work hours for when you're functioning at the best, like early morning, or maybe you need to come in a bit later. Chemo brain is really common after any chemotherapy, but also after a transplant. You might find that you're not as organised as you used to be. Your ability to concentrate is decreased. You have trouble remembering things, and it takes longer for you to complete routine tasks. And stress and tiredness contribute to chemo brain. There's really no established kind of treatments for chemo brain, but you can try things like writing notes and lists to help you remember and organise yourself, avoid multitasking, do difficult things earlier in the day when you have more energy, eat well, exercise and get a good night's sleep, exercise your mind, so with puzzles and Sudoku, etc. It will improve, but once again, it's a slow process. So in summary, the first year after your transplant can be a bit of a roller coaster. There are lots of achievements and firsts which need to be celebrated, but sometimes there are lows and setbacks which can be dispiriting and frustrating. Today we've highlighted some of the things that you might experience, like fatigue, infection, graft versus host disease, the fear of relapse, and issues with sexuality. We've also gone through returning to work. I've only touched on these topics very briefly. There are resources that you can hook into to provide some more information. So please contact your transplant team if you've got questions or concerns. And LBC provides an amazing service to support and advise you and help you through these issues. There's also some very good online resources that you can access. Just make sure that they're from reputable organisations like transplant centres or organisations like LBC. I'm sure that there will be a copy of these slides online, but there's a few resources there that might be helpful for you. And with that, I'll leave that there. Thank you.